At what point in treatment should stem cell transplant be considered, and is there a best time to have it? There are 4 times or 4 reasons for getting a transplant. The first is upfront transplant when you're newly diagnosed. The second is delayed transplant after some therapy. The third is salvage or second transplant, essentially a second transplant after you've already had one. And the fourth is to bring your numbers down in preparation for a clinical trial.
Most of the transplant that we do for myeloma patients is done as what we call an upfront transplant. That means a person gets diagnosed with myeloma, we kind of decide with the person is a candidate for transplant. In such patients who are eligible, after a period of about 4 or 5 months of initial therapy that is designed to control the disease, then we feel that the person is fit enough to give us stem cells to collect and freeze, and then we take them immediately to transplant. That is called an upfront transplant. Most of the transplant studies that were done, which established this modality of treatment, were done in this setting where patients got initial treatment for about 4 to 5 months, then got an autologous transplant, sometimes a tandem transplant where you get 2 back-to-back, versus they were compared with people who just continued on chemotherapy. These studies have shown that the people who got a transplant had a longer remission. We call that a longer progression-free survival, which means they had a time of remission or freedom from progression of myeloma that was longer than if they just continued on chemotherapy. And in some of the cases, they had a longer overall survival, which means that if you follow these patients out for a greater length of time, the people who got transplant ultimately lived longer even after multiple relapses, etc. Autologous transplants got established in the early 90s and have to this day always in every study that has been done has provided a longer progression-free survival for the patients who got that versus just continued on chemo. So that's the role for upfront transplant.
High-dose melphalan with autologous stem cell transplant or rescue should be considered for newly diagnosed myeloma patients. I don't put age as a number, but if patients are fit or even intermediate fit, they should at least have a discussion. But I think having that conversation is important in the newly diagnosed setting.
You can also have a transplant in a person who stored their stem cells up front, but then chose for whatever reason not to have a transplant right away. And then when they relapse, after the first line of chemotherapy fails, they could have a transplant at that point. That we call a delayed autologous transplant.
If the patients for some reason decide not to get a stem cell transplant or did not have access to it as part of their frontline treatment or had at least 3.5 to 4 years benefit from the first one, and they're still young, and that would still be an option. They should be offered that opportunity during their first relapse. The more advanced myeloma patients get, the less bang for the buck you get with high-dose melphalan.
The third setting is when someone who has had a transplant and they were in remission for several years, when they relapse, they can get another treatment which puts them back in remission and then get a transplant to make that response last longer too. So we call that salvage transplant. I don't like that term, but that's what people call it.
In the relapse refractory setting, in a more advanced patient where you already have the stem cells stored up in the freezer, when the blood counts are declining, we tend to utilize high-dose melphalan with stem cell rescue to help augment the patient's blood counts, because if the blood counts, especially the platelets, if they're low, patients may not qualify for a clinical trial. So that's where we would utilize it. It would be a temporizing measure to get patients to a clinical trial.
Why is upfront transplant the best option for anyone considering this treatment?
One of the questions I get that asked a lot from patients is that, should I do a transplant now? Should I do it later? I think when it comes to an autologous transplant or the standard transplant that we do for myeloma, most of the data would point to the fact that you should do it earlier in the disease because that gives you a longer first remission. And a longer first remission translates to basically better quality of life because you got a long first remission, say 4 years, which is the average you get these days. 4 to 5 is the average we quote for patients with standard risk myeloma. Myeloma then becomes a blip in your life for about 6 months. That happened 4 or 5 years ago. The biggest advantage I see to doing a first transplant is that 5 years later, given the history of how we've been treating myeloma so far, your choices in terms of drugs to treat your first relapse 5 years later from your diagnosis is so much better.
So I've shared these data from a big international myeloma working group study that we did, collecting data on more than 7,000 newly diagnosed myeloma patients going through stem cell transplant trials around the world, showing that patients who get to a complete response or better during their first year of diagnosis have almost a 3-year overall survival benefit compared to those who did not achieve complete response. The reason why I bring that up is picking the best available strategy strategy to get your patients to the best depth of response during that first year of diagnosis is important. Historically, we have had examples and anecdotes of patients doing exceptionally well with just a little bit of treatment, but those are exceptions. They're not the rules. And, when you look at data, you don't say, oh, there was once a patient that I treated with just salt and they did well for 15 years. You don't say that. You look at the data objectively and you look at the whole population, and then you come out and make a statement. I think it's important for us to, consider that. So depth of response is important. What you do for our myeloma patients during that first year of diagnosis is very important. That's our best chance to get patients to MRD negativity. So in that context, I think at the current moment, high dose melphalan gives that patient who's coming to see you the best chance of getting that depth of response in combination with the rest of your therapies. It should still be considered a standard of care.
I still think it's reasonable for patients to consider high dose therapy, especially if they're younger, because as you get older, it may be a little more difficult to tolerate the high-dose melphalan. It's not fun. It can be anywhere from 1 to 3 months of recovery from that, because it does wear the patient down. And a lot of patients, even after they have count recovery, will go home saying they're quite fatigued, and it can take several weeks to get over that fatigue. But usually by 3 months after the stem cell transplant, most patients are back to close to normal, and definitely by 6 months. And most of our patients, if they're young and have a job, are usually back to work within 3 months. Now, it depends. If they do heavy-duty manual labor, it may need to be longer. If it's a desk job, it's probably shorter. But even then, some people have trouble concentrating. Why? Because they're feeling tired from the effects of the high-dose melphalan.
Are there reasons to delay transplant for anyone considering this treatment?
Stem cell transplant still has a role. And when you compare it to no transplant, you obviously have great advantages, both in terms of response, in terms of duration of remission, in terms of overall survival, life expectancy. But the question about upfront versus delayed transplant, and there one can come up with the argument that, well, even if I delay the transplant, and studies have been done, there are at least 2 large randomized trials, one early on in 1998 by the French group, and the second one in 2017 by the other French group, but by incorporating all the newer treatment. And they both more or less showed similar results, that with upfront stem cell transplant versus delayed transplant, more patients achieved complete remission. So depth of response is there with upfront transplant versus delayed transplant. Number 2, progression-free survival is longer with upfront transplant. But overall survival was about the same. But then, especially in the more recent trial, given the effective treatments for myeloma, we may want to wait a little longer before we say that overall survival is about the same. But one can make an argument for a delayed transplant that, well, I would rather delay treatment to later. But my counter argument to that would be that if your intent is to achieve the deepest and the most durable remission, then this upfront is the time. Because we know that with modern treatments, based on some of the recent trials, the first remission can last on average between 5.5 to 6 years. And it could be much longer in patients who have deeper remission or who do not have high-risk chromosomal abnormalities. So you achieve a deep and durable remission. Post-transplant, sure, patients do need treatment, but in this day and age, that treatment is quite manageable. And clinical trials have shown that patients have taken Revlimid or lenalidomide for extended period of time, or even high-risk patients have taken a proteasome inhibitor, whether it's bortezomib, and now, of course, more data coming out with ixazomib. So you can do upfront transplant, and you can stay on maintenance treatment, maintaining a fairly decent quality of life. And this was shown in actually the French study that was done in the 90s. Some of the other arguments in favor of upfront transplant that I make to my patients also include that you want to get a more intense treatment when you are younger and in better health. Again, with time, no one gets younger, and with time, of course, we can develop other diseases. So later on, you may not be eligible for high-dose therapy, either because of age, because of some other morbidity that someone developed. Sometimes it's the disease that has become more resistant, and you get much less out of that transplant than you would get upfront. Again, it's more of a philosophical argument, but as a transplanter and looking at the overall data, I try to convince patients with upfront transplant, but I fully respect someone's decision when they decide to delay it to a later time.